have also zero nerve. This zero nerve is much more important for animals because this is a nerve which is the nerve of innervation of Jacobson organ or nasovomoral organ, which is localized in the palatum. In some animals, you very well know that Jacobson organ, probably you know, that is important for analysis of the chemical compounds dissolved in the air for snakes, but also for horses, cats. But last 5 years said to us that also in human, some information could be transmitted into the brain from this organ, which is localized in your palatinal region, but in human it's very rudimental. So this is a zero or O nerve, so not too much important in human. But the next all 12 you have to know. So olfactory nerve, optic nerve, oculomotor, trochlear, trigeminal, facial abducent, trigeminal abducent, facial, statoacoustic or vestibulocochlear, glossopharyngeal, vagal, accessorious, and hypoglossal. So here is a list of names in Latin and also in English and in Czech to understand to all those. I have said last lecture that we have some organization of nuclei or gray matter in the neural tube, which is a general, and this general assemblance is also seen in oblongate and mesencephalon, and also in between pons, where we have a nuclei for those cranial nerves. Those cranial nerves could have a motor and sensoric functions, but we can divide it in somatomotor, branchiomotor, visceromotor, so 3 kinds of motor. When somato and branchio, they innervating stripped muscles, and visceromotor innervating smooth muscles and glands. Then we have a viscerosensitive or viscerosensoric. So the viscerosensoric is important sensations of the tension and content inside the gastrointestinal tube, but also in those parts which are embryonic gastrointestinal tube, like trachea, bronchi, lungs, nasopharynx. Then we have a somatosensoric. Sensoric, we know from extremities and trunk that they could obtain information about tactile discrimination, but also about conscious proprioception. So the information about the skin sensations and the sensations from the muscles and tendons and ligaments. The last one, sensoric. In Czech, sensoric, it's in English special sensoric. And a special sensoric, we have that our special senses are some senses for distant sensations like vision and smelling, so olfactory and visual system. But this is this smell or olfactory vision, and here is gustus, so taste. And taste is a part of a sensation which is much more close to the viscerosensitive, because it's a chemical analysis of a content inside the gastrointestinal tube, especially in the stomodeum. So this is really, again, something like viscerosensoric. Why we name nerves by the numbers? The numbers are for us the numbers from cranial to caudal, how they are emerging from the skull. according to the holes, fissures, where the nerves are emerging outside from the skull, but not the position from cranial to caudal, how they arise from central nervous system like brain, brainstem, and also spinal cord. Because when we look here, this is a first nerve, olfactory, second, optic, and here is a three nerve, 3, 4, this is a 5, this is a 6, here we have a 7 and 8. So here is a jugular foramen, where is a 9, 10, 11, and the last is a 12. So those are nerves, how they are arising from the skull, entering some holes. But in reality, you can see that here in the brainstem, the organization of those nerves are a little bit more chaotic according to the numbers, because the last one, which is arising from the spinal cord and oblongate, is a 11th nerve, and here is a 12th nerve, which is arising from an oblongate higher than 10th nerve. So this is the logic how we name those nerves, how they are emerging from the skull. So one more information, that nuclei of cranial nerves, nuclei which could be motor or sensoric, and from motor, somatomotor, branchiomotor, and visceromotor. So visceromotor in a head region, it is a parasympatical, and then viscerosensitive, and somatosensitive, and special sensitive. They have the positions from the medial line. The medial line is represented by sulcus medianus in the floor of fourth ventricle, which is called rhomboid fossa. And here is the section which is through the lower part of a fourth ventricle. You can see here the olivary nucleus, and in this region we have here 12th nerve, somatomotor. Then there is this, which is dorsal vagal, which is a parasympathetic. Here is nucleus ambiguus, and we will see how it's shared with 3 nerves, which is a branchiomotor. So branchiomotor, it signs that it is innervating the muscles, stripped muscles, which are originally developing in the branchial fissures in a fish, and during the development of embryo, in the period where the embryo is very similar to organization of the body of the fish. And then we have here splitted nucleus of solitary tract, which has a special visceral gustatory fibers. Also this part of the nucleus is called gustatory. And here is a general visceral efferent, which is obtaining the information from tension and filling, for example, of gastrointestinal tube in the abdominal region, how you have filled your stomach or gut. And then we have here laterally vestibulocochlear nerve, nucleus, so vestibular nuclei. And the last one is a spinal nucleus of trigeminal nerve, because it is a, if you remember from last lecture, it is a very, very long nucleus which takes the sensations from many parts of the head, of the skin sensations, which are here relayed in a sensoric pathway, and also this is a part where some additional fibers from other nerves which contains which contain the sensoric information. So this is the tube which is not completely rolled in the floor of the rhomboid fossa. And now we turn to those nerves. The first nerve is the olfactory nerve. Olfactory nerve is a nerve which is in reality the extension of telencephalon. It is providing the information about the chemical substances which are also dissolved in the air, and when we can see here those structures which are localized in intracranial part here. This is a bulb, bulbus olfactorius, and the tract, which is a tractus olfactorius. Then the pathway of the information is divided into the primary parts of a so-called olfactory brain, also rhinencephalon, which is localized in the base of the temporal and frontal lobes. And then it's also associated with the parts which are localized here. The blue one is important structures which we will have during basal ganglia. It is amygdala, and the surrounding tissue is a so-called entorhinal cortex. The information from olfactory nerve is very important for emotional imprint into the brain, into the memory, because if you can imagine that we are all also on the same level like animals, like cats, dogs, horses. When you have the information from environment, from some chemical substances, you can smell, for example, pheromones. You can smell the animal. You can smell the flower, the orange. Then the information about this feeling is associated with some which is important for you, so some emotional plus or minus. So if it is orange, you can eat it, and then when you feel that the orange is not very well smelling, so then you don't know if you can eat, and when you smell some odor, you know that it is not to be eaten. So these primitive imprints are associated with emotional things, but in our situation it is much more developed, because those informations could be associated with visual, hearing, reading, imagination, etc., etc. But it is this very primitive thing which is very well developed in quadrupeds. So this is a olfactory nerve. The olfactory nerve has its initial part which is localized in the olfactory region of a nasal cavity. So this is a septum, and you can see that those olfactory phyla are localized in the nasal cavity, and they are going through the cribriform lamina, which is a plate which separates intracranial space from the nasal cavity and is a part of ethmoid bone. So there are the endings of neurons, which are one of the most primitive, they are then relayed the information into the bulb, and from the bulb, the information is relayed into the brain. What's interesting, the olfactory nerve is only one which is not relayed in the thalamus. Thalamus is a gate to the mind. For all other information, we have a relayed neuron which is localized in the thalamus, but only olfaction is not relayed there. The second nerve is optic nerve. Optic nerve is again only the extension of a central nervous system, because of it is a lateral vesicle of the encephalon, which is created there, and then we have it, the eyeball we have in the front of the face. But in general, if you look at other animals, for example, if you look at a horse, if you look at a fish, they have eyes really laterally, more laterally, because they have the information, the visual field larger than we, but we have one important advantage, also like cats, that we have the perfect binocular vision. So then, this is the reason why we have eyes in the front of our face. So why it is only the extension of intracranial space? We have ganglional cells and we have retinal cells, rods and cones, which are in the retina. And the retina is the specialized central nervous system tissue, and the retina is a part of a central nervous system. The optic nerve, which is here in a yellow, this section of the optic nerve is covered by layers of meninges, and the vagina, which is around the nerve, is developed from the same layers like leptomeninges and pachymeninges. And please remember a very important thing, that the tumors which are arising from optic nerve are the same like we can see in the brain. Inside the optic nerve we can see some glial cells, some astrocytes. So then we can see here astrocytoma. The coverage around could be cause of the proliferation of meningeal cells. So then we can see here meningioma. So this is very important. The optic nerve then is going into this cross, and this cross, St. Andrew cross again, is the site where partially the fibers are crossing, partially are not crossing. This is called chiasma. Chiasma is a part where are crossing parts of fibers and the other are remaining not crossed. Why partially it is crossed and partially not? Because here are crossed the fibers from visual field. So typically when you have this field, it's from this part of retina and this part of retina, and those fibers are going to the other side the same way. And then here is a field where is a primary visual cortex. So then the organization is made that the information is crossed from the same visual field, the part of visual fields. Then the information could be integrated and could be performed the double vision in one, so stereoscopic vision, which is for us very important. You can try, when you close one eye, then to hit your tip of the nose. That is not easy to do it when your one eye is not closed. So this is the important thing. You have to do it from distant. So then, this information which has shifted this 10 centimeters is counting with this very important shift. So then, tractus opticus is a path which is then following and going to the thalamus region, to the corpus geniculatum laterale, lateral geniculate body, and from this is optic radiation, and this is information which will be one more time repeated during the functional neuroanatomy. So very important is to distinguish optic and ophthalmic nerve. Optic nerve is a nerve which has a vision information, visual information. The ophthalmic nerve is a sensoric, but only somatosensoric. And this is a special sensoric. It's in English a little bit confusing. In Czech we have a senzitivní and senzorický. Probably also in German it's a sensitive und sensoric. But English it is the same. So then we have to say special sensoric. Special sensoric are olfaction, vision, balance, and tactile and taste. Yeah? So this is very important. So then the information which is obtained from the optic nerve is information about vision, about the light which is hitting the retina. The ophthalmicus, which is a first branch of a trigeminus, taking the information from skin, from lacrimal gland, from the orbit, from the nose, from the anterior part of the intracranial space, taking the information about the pain, tactile, the other sensations, but not about the vision. So everything other than optic information. So then we turn to the group of nerves 3, 4, 6. Those 3 nerves are innervating muscles. So then they are somatomotor. So somatomotor, it is like to be skeletal muscles. So like you have muscles of the arm, biceps, brachii, etc. Because they are really arising from the skeletal structures. Those 3 are named oculomotor, then trochlear, and then abducent. So 3, 4, 6. You can see here that 3 and 6 are arising directly in the anterior aspect of the brainstem. Mesencephalon 3, ponto-oblongate interface 6, and the 4 has a special curse. The special curse is that it is only one nerve arising dorsally, rolling around the brainstem, rolling around the level of a pons, and anteriorly you can see those nerves. And the speciality of a trochlear nerve that the nerves are crossed So the nucleus for left is on the right side and vice versa. The other have the same size, the same site on the same sides. So, important thing, if you remember last lecture, we have discussed the problem of a mydriasis. The oculomotor nerve is a mixed nerve which contains also visceromotor. Visceromotor autonomic part. This autonomic part is the parasympathicus. And parasympathicus is for the ciliary muscle. And the second is sphincter, pupillae. So those two muscles are contracting according to the impulses from this oculomotor additional nucleus, which is called, I have told you that is a name, remember it? Yeah, for those who are from Westphal, is this easy to understand? So this Edinger-Westphal nucleus is very important, is a very prone to be damaged in compression. And the nucleus which is affected by the compression during some space-occupying lesion which is localized in the supratentorial region, so in a large brain, for example, bleeding, tumor, etc., it could cause the compression and impairment of the function, and the patient could have on the same or the other side the dilatation of a pupilla which is not reflecting to the light. So then this is called then mydriasis. Mydriasis is a very, very important sign that the patient is endangered. If you have an unconsciousness in the patient and one pupilla is dilated, not reflecting, so that is a very danger. When both, it's very important that the patient could have so high intracranial pressure that could be probably with a brain death. So about those three nerves, how they are organized in the orbit. The orbit has two entrances from intracranial space. One entrance is optic channel, and the second is superior orbital fissure. The superior orbital fissure is a place where three nerves are entering the orbit. So here, 1, 2, 3. And you can see here that two of those nerves are going through the ring of Cini, so tendinous ring, which is the origin of eye-moving muscles. And those two nerves which are going through this ring are those which are innervating rectus, so straight muscles. So this is a 3 and 6. They are entering. The last one here, you can see this sling. This is a trochlear nerve, fourth nerve. And trochlear nerve then is innervating this only one muscle, which is with the tendon bowing around the trachea, and it is a superior oblique muscle. And also the only one muscle innervated by sixth nerve is this is a lateral rectus muscle. So lateral rectus muscle, it's easy to remember because abduction is a movement outside to the lateral. So then lateral muscle is innervated by abducent nerve. The all other muscles inside the orbit, stripped muscles, are innervated by this last third nerve. This is collection of three rectors: superior, medial, inferior, then inferior oblique, and the last one is a levator of a superior eyelid, so levator palpebrae superioris. Here it's seen also on the images, and this blossom here, you can see here, ring of Cini. You can see that into this is entering this one. This is a second nerve. And here, divisions of third nerve. This is the sixth nerve. You can see here nose, and here is a zygomatic. So this is a medial, this is a lateral. And the last nerve is going this way and innervating by this way behind muscles. This, which is a trochlear nerve, and muscle, which is superior oblique. The last branches, which are here, are branches of V1, so trigeminous first branch, which is called ophthalmic. And this structure here is superior fissure. So ophthalmic nerve is a part of trigeminus. Trigeminus is the most thick nerve which is arising from the brain stem, and it's going through fibers of white matter in the region of lateral aspect of pons, and it contains branchiomotor part, and branchiomotor part is innervating which muscles? Yes, chewing muscles or muscles of mastication, and other? Do you remember? And two muscles which are also important because they are arising from the same level of branchial fissure. So it's a musculus tensor tympani. So tympanal tensor and veli palatini. So tensors are also innervated by this nerve. So this is branchiomotor. This branchiomotor nucleus is localized in a pons, and then it's creating the separate band, which is very frequently side by side with the sensoric part of the trigeminus. So like a small band which is lying on the large cable. Sometimes it's included, but it is a motor. So the direction of information is outside. But important is that the major function of a trigeminus is a sensoric. And it's a typical nerve which has a somatosensoric. So it's a somatosensoric. What is this information? This information is obtained from the skin, from the proprioception, and also sensations from meningeal coverage of the central nervous system. We can divide the nuclei into three parts. One is called mesencephalic, the second is part principal or pontine, and the last one is spinal, which is localized partially in oblongate, but quite long segment is localized also in the upper spinal cord. So then the trigeminus obtains the information from the large range of tissues in the cranial part of the body, so in the head and partially from the neck also. So, interesting and important is, probably you can see that we have some relays, and this is a part which is called ganglion. And ganglion here is called gasseri or nervi trigemini. So this gasseri ganglion is lying on the superior aspect of an apex of pyramis, and there are pseudo-unipolar nerves which takes the information that is relayed here in the nucleus. So this is something which is analogic to the spinal ganglia of the spinal nerves. So there are sensoric neurons, sensoric pseudo-unipolar neurons, taking the information about the skin sensations and proprioception from the head and partially neck. So this is trigeminus. This is the organization of the intracranial part. The extracranial part is much more complicated. We can divide trigeminus, like the name says, into the three branches. The most cranial is for us now known ophthalmic nerve. Ophthalmic nerve is arising from ganglion and then is divided into the nasociliary nerve, and then to the lacrimal. And those two branches are entering the orbit like separate. Nasociliary, then you can see that one is going to those foramina at moidalia and innervating nasal cavity, and then also lateral part of nasus outside. And ciliary because it is going into the eyeball and then it's innervating the eyeball, the sensitive information of the eyeball. So the pain which could be felt from the eyeball or from the orbit. So this is two branches. Lacrimal then is divided into the branches which are really innervating lacrimal gland, but then they are escaping outside from the skull through the notch or sometimes foramen supraorbital. And the supraorbital foramen is palpable, and you can then touch the superior branch of the ophthalmic nerve. And the palpation here is a major thing when you perform investigation of the patient. So then this is an examination point of the innervation of a superior branch of the trigeminus. So this is ophthalmic nerve, and one important branch is remaining. Probably you can observe this one, and this one is going into the meninges. And then it's important that the ophthalmic nerve is innervating the very large part of intracranial space, except occipital bone and around, so posterior fossa mainly. And this is the innervation which is leading the information about the pain when the patient has a meningeal problems, bleeding, infection. The second branch is a maxillary nerve. Maxillary nerve is again pure sensoric, somatosensoric nerve. Somatosensoric nerve is then going into the channel which is made from foramen rotundum, round foramen, and then it is going into the pterygopalatine fossa. So then it is branching here like maxillary artery, very similarly, and creating some important nerves. One important nerve is infraorbital, and infraorbital groove or partially channeled, then emerging from the skull in infraorbital foramen, and this is a point for palpation of the second trigeminal branch. This trigeminal branch is then innervating everything which is below the tip of the nose and the rima palpebrarum, so the fissure between eyelids, so which is between this and between the oral fissure. The other things which are innervated by this nerve are teeth and alveolar spaces, also gum with the alveolar branches. They are partially, the first, the anterior, are innervated by infraorbital branch, but the middle and the lateral or dorsal are innervated by the branches which are localized dorsally and arising behind the wall of the maxillary sinus. This is the reason why it's a very different for anesthetics in stomatology than when you have anesthetics in lower jaw. There is only one point from which you can perform local anesthesia of the whole mandibular alveolar spaces and teeth, but in maxillary it's not too easy because you have to change the position of a needle of infiltration when you have anterior teeth or dorsal teeth. So this is maxillary nerve. Maxillary nerve is also important because it is taking some branches which are connected to this structure which is called ganglion pterygopalatinum. So pterygopalatinum, which is important, and we will talking about it structure in facial nerve. So mandibular nerve, third branch. This is partially branchiomotor and much more sensoric. So this is a minor motor. Motor branches are branches which are innervating those muscles here and here, and those which are localized in palatum, and also the tensor tympani is going with side by side with the Eustache tube in the channel, going and entering middle ear. So those are branches for those muscles for muscles of mastication, so masseter, temporalis, and lateral and medial pterygoid muscle, and mylohyoid. So it's important to understand which muscles of the head are innervated by trigeminus and which are innervated by facial nerve. Trigeminus, they are mastication or masticators, and those are mimic muscles. This is on the face and on the head. So all masticators are innervated by trigeminus. The other thing is sensation from the skin, the sensoric. Sensoric face, the whole face except small posterior auricular nerve territory, are by the trigeminus. So this is very important to distinguish that we have a motor functions of both nerves. But first, trigeminus, innervating mastication, facialis, facial nerve, facial muscles, mimic muscles. So the innervation of a trigeminus could be seen here. Those are territories of those three branches. What is innervated by which part? Here you can see V1, V2, and V3. I have said that the line which is important is the tip of the nose, medial angle, then rima, and then towards the position where we have the end of a sagittal suture and the start of the lambda. And the lower part is again easier because there's a rima oris and then obliquely to the same point. So we have here a discussion about the territory of muscles, so this is clear, there's mastication. But interesting and important is the innervation of inner space of nasal cavity and paranasal sinuses, and then also the oral cavity. The nasal cavity, where we have a septum and where are no conchi, so then this is a territory of V1, and V1 has also territory in the frontal and also sphenoid sinuses. The rest of nasal cavity, where we have conchi, and also up to the region of the orifice of tuba auditiva or eustachian tube. This is the region of V2, so maxillary nerve. Maxillary nerve innervates also palate and the upper part of vestibulum oris. The rest, lower part of vestibulum, oral floor, and the part of the tongue, but the tongue up to the V-shaped terminal sulcus are innervated by sensoric information by V3. So sensoric. Sensoric information. So now we turn to the second nerve. We skipped 6 because it is one of the oculomotor nerves, which is called abducent, and we turn to facial nerve. Facial nerve is very, very important again, and is a mixed. it has three qualities. Branchiomotoric part is a nucleus of facial nerve. This nucleus of a facial nerve is localized below the below the floor of the fourth ventricle, and those fibers making a sling around abducent nucleus, which is on the same level, and then they are going laterally. Then we have other important nuclei, superior salivatory nucleus, also nucleus salivatorius superior, which is a visceromotor, and visceromotor then which is visceromotor, so it's autonomous and it is a parasympathetic. And then it has some somatosensitive part which is very, very rudimental, and it is going to the spinalis part or spinal part of trigeminal nucleus. And the last function, which is very important, which is a gustus, so taste, and taste is a nucleus tractus solitari, so pars superior, superior part. So here we have those nerves. This is a motor, so this is this direction, going through this part and going into the muscles. You can see here some branches. This is a branch for stapedius. Stapedius muscle is the smallest muscle in human body, which is localized in the middle ear and making a tension of a stapes to modulate the proper tension of the ossicle chain. The next one is for muscles which are arising from the region of styloid process, and for example dorsal belly of the gastric muscle. And the last is for all facial muscles, so mimic. So this is a motor branch or motor part. Visceromotor part, and look at this. Visceromotor is here and makes one branch here and the second branch here. This branch is then forming nervus petrosus major, or major petrosal nerve, which is supplying by parasympathetical preganglionic fibers the pterygopalatine ganglion. And the second is the branch which contains part of a chorda tympani, and chorda tympani provides the parasympathicus to the submandibular ganglion. Important. So parasympathicus. And the last one is a sensoric information. I've said is a taste. And the taste is going into the same part and is associated in chorda tympani. So chorda tympani obtains centripetal fibers which are for a taste. So you can see that the curse of the facial nerve is a little bit more complicated, and you be satisfied with it. And the problem is that it is a semblance of different fibers. So what we can then also remember, the curse of the facial nerve is that it is emerging the brainstem side by side with statoacoustic nerve, and with the statoacoustic nerve it is going into the internal meatus, which is somewhere here, and here it is entering petrosal bone, and in petrosal bone it's making a curve, and in the curve in a knee part is a geniculate ganglion, where is localized pseudounipolar neuron for sensations of a taste. So again, similarly to the ganglia of spinal nerves. So facial nerve then is going through the petrous bone, arising from it also the chorda tympani, as I said, and then finally it is going to the opening which is called foramen stylomastoideum, and stylomastoid foramen is localized between styloid and mastoid processes, and here then it is branching to the nerves which are going into the muscular layers of the skin muscles, because mimic muscles are original skin muscles, but also it has some branches for more deep localized muscles which are arising from styloid process, so styloglossus and then also digasticus posterior part. What's interesting and important for the clinical praxis is the innervation and the lack of innervation of the face. It is interesting, and accidentally it's very helpful in the neurology, that we have two parts of the innervation territory. One is in a frontal region. So to make this rings or wrinkles, it is made by muscles which are in the fronts, so it's a frontal muscle. And then we have other which are making motions around oral rima. So then, when you have some paresis, you can see that the patient has depression of the angle of the face, of the oral angle. But important is if you have or not have also paresis of the upper part. Why sometimes it is, why sometimes it is not. We have different relay of the first motor neuron. First motor neuron is localized in a precentral gyrus. The upper part, the frontal part, has a double relay. So it is a relay to the one, relay to the one. So bilateral. Also here is a bilateral. Then when you have here bleeding or ischemia, and this is not working, then is still relayed from the other side. So then, when you have a central paresis, central cause of the impairment, then you have only lack of function of one part of the oral angle, not impaired functions of wrinkles on the frontal region. The second part is crossed. So from left to right, and then it's going this way. So when you have a central, you have only one side angle. But when the problem is here, is somewhere distal from the brain stem, then is impaired this function and this function. So then you have a leg here, so this is a peripheral paresis. So please remember it, because the paresis of a facial nerve is very frequent in two situations. When you have a patient with a central paresis after brain ischemia, you have only affected the angle. The second could be during a cold, during some virosis, during the infection in the middle ear, with the affection of a petrosal bone, or during the fracture of a skull base. Then you have the impairment of both those parts. So then it is a peripheral which is seen on the half of the head. So important. So according to the course of the nerve is entering the petrosal bone, and then it is going this way and making angular sling, and here is a geniculate ganglion. This is a pseudo-unipolar for posterior auricular nerve, and pseudo-unipolar for taste sensations from chorda tympani, from the anterior two-thirds of the tongue. Then we have important branches. I have said this is a major petrosal bone, which is then going to the ganglion pterygopalatinum. Next nerve is here, small nerve for this smallest muscle in a human body, making a tension of the system of ossicles. And then third branch, seen here, this is a branch which is called chorda tympani, which is going in a fold of mucosa in middle ear and entering the fissure between here, hammer and incus, and then is going into the synchondrosis between petrosal and sphenoid bone, and then going outside, and you can see that is joining with this nerve. What is this nerve? This is a mandibular. And it will be interesting and important on next slides. And then is going outside, and here those are emerging branches for muscles and also auricular posterior nerve. So then we can distinguish also important sections where we have some impairment, because the whole nerve has information about sensations, especially taste through the chorda tympani. Then we have stapedial nerve, muscle, which is very important for the tuning of our ossicle chain to hear well. And next is a great petrosal nerve, and here is also chorda tympani. So those parasympathicus is very important, because when you have a leg here, you have xerophthalmia, so you have a patient without production of tears, and also no salivation in the major salivatory glands like submandibular and sublingual. So then you can distinguish where the lesion is. Or it's completely peripheral when it's only muscular innervation impairment. So about parasympathicus of facial nerve. Remember it once again that we have two ganglia which are supplied by this nerve. So from nucleus salivatarius superior salivatory nucleus. They are pterygopalatine and submandibular. Pterygopalatine is relayed here, so preganglionic nerve, then supplying lacrimal glands in the nose, and glands also here in the upper part of the oral cavity, palatinal, and in the upper part of vestibulum. The ganglion submandibular is then important for salivation from two major sublingual and submandibular gland. What's interesting and important, we have some bridge which is called chorda tympani. Chorda tympani is localized in a middle ear and leading except those fibers into the ganglion, vice versa, also taste. And then the chorda tympani is joined with the mandibular nerve, but its branch, which is called lingual. And we know that lingual nerve is one of the branches of a mandibular. So then, it's important that taste from the tongue and the somatosensitive sensations from the tongue. So, you can touch with the tongue, your oral cavity, and you have a feeling like to touch with the fingers. Then you have a pain here. Another thing, so pain and touch from the tongue are streamed in the same structure like the taste, but then it is divided in information, and taste is led by chorda tympani into the facial nerve, and the somatosensoric sensations from the tongue, anterior 2/3, is taken by the mandibular nerve, the third branch of a trigeminus, and then is going into the trigeminal nerve, sensoric nucleus. So we turn to next, statoacoustic nerve. Statoacoustic nerve is also complex. It's in reality in a part of a somatosensoric, but it is a special somatosensoric. So then it is a česky oder in Deutsch sensoric, real sensoric, not sensitive. So, what information we can obtain and from which parts? There are cells, and we will have it once again, which are localized in ampulla of semicircular channels. Semicircular channels obtain information about the rotation motion of the head. Those three semicircular channels are perpendicular together to form a 3D model of the space, but also it's not only one, there's a second. Also we have two. We can make sensations from both sides. So this is a rotational information. The planar, so linear motions are then also obtained from two endings or starts in utriculus and sacculus. So then we have 5 wires from vestibular path, and those 5 wires forming then ganglia. In reality, there are 5 ganglia, and those 5 ganglia are assembled into the 2 parts. One is superior ganglion, which is called ganglion vestibulare pars superior, superior part, or also utriculo-ampular, takes information from anterior lateral, it's true, ampulla and utriculus, and inferior from posterior and sacculus. Here, this is the inferior part. And then it's joined, here it's relayed again, the information. So, and then this is also something similar to spinal ganglion, and the information is going into the vestibular nuclei. The different situation is cochlear nerve. Cochlear nerve is localized in cochlea, and you can see here this 3D spiral. And from 3D spiral, you can see too many ganglia or smaller units, which are then assembled in ganglion spirale, which is a 3D structure. What's in reality? In reality, the same organization are in those ganglia or in spinal ganglia. But here, because it is really in this rounded structure, distributed, so then it's extended in this chain. And this is very important. Then we have here tonotopic localization. You know that several parts have different sensations and they are sensitive for different frequencies of a sound. So then this ganglia, those ganglia also. Then it's forming cochlear nerve, which is associated with vestibular nerve and entering brainstem. And when it's brain, when it's in the brainstem, then it is divided also. The information then is going to the 2 parts. Two parts which are important are vestibular and cochlear nuclei. Vestibular nuclei are 4. They are localized more medially. And we have a Bechterev, Deiters, Schwalbe, and Roller, and they are then relayed into the brain stem. And they are relayed then also into the olivary nucleus and cerebellum. Cochlear, which are most lateral, they are anterior and posterior, and they are relayed then upwards into the telencephalon through the relay, which is localized in collicular region, in collicula inferiores, in mesencephalon. So here are the ways of the information. The information of statoacoustic, they are going into those 4 ganglia, but also directly into the cerebellum, into the vestibulocerebellum. So quite old, so archicerebellum part. The second information from acoustic part, from cochlear nerves, are then distributed here and relayed in those nuclei which are localized nearby olivary region. So oliva is here. So this was the nerve which is called vestibulocochlear. Quite easy to understand how it's organized. Next two nerves, they are mixed nerves. They are like a twins because they have very similar functions. So they have important parts which are similar, and they are sharing some nuclei, sharing those three nuclei. And only one is special for glossopharyngeus, and this is salivatory inferior part. The salivatory then is providing the information for information from otic ganglion. So we can distinguish then again branchiomotor. Branchiomotor nucleus is nucleus ambiguus. Nucleus ambiguus is a long ganglion which is separate in three parts. The superior part is for 9th nerve, the middle for 10th, and the lowest for 11th nerve. Viscerosensitive is for tractus solitarius. Tractus solitarius is quite also long. The upper part is for the glossopharyngeus, and there is also a part where is the center for taste. In the superior part is also center for taste, for the fibers from chorda tympani and lingual nerve, and from the tongue, and from the 7th nerve. Then the glossopharyngeus nerve is going outside from the brainstem, and we can distinguish two ganglia. Two ganglia are localized, one intracranially, the second extracranially, in the level of foramen ugulare. Foramen ugulare. In the upper part is a pseudo-unipolar neuron, which could be seen here, and this is nerve which contains the fibers about proprioception from muscles and sensations from the surface, inner surface of the territories innervated by glossopharyngeus. So it is similar again to the sensitive ganglion on a sensitive root on a spinal nerve. The other pseudo-unipolar neurons are localized in the inferior ganglion, and in the inferior ganglion are led the viscerosensitive and gustatory information. Viscerosensitive about the tension inside the gastrointestinal tube, so in the pharynx, and the taste. And the taste is where? Taste is from the base of the tongue. So this is a 9th nerve. So the glossopharyngeus nerve is a nerve which is going through the foramen ugulare with 10th nerve and 11th nerve. Here is seen glossopharyngeus. From glossopharyngeus there is a nervus which is called nervus tympanicus, and we will see it in a second on the next slide. And then here we have another branch, another ganglion, and after this ganglion we have branches. The branches are sensitive branches for tonsillar fossa and tonsilla palatina, then for the base of the tongue, and then also they are motor nerves for the pharyngeal muscles, making the manjette of a superior part of a pharynx in the oral and especially nasopharynx. The last important branch is a branch which is seen here. This branch is going to this body. This is a carotid body, and this is a viscerosensitive information which is obtained through this way from the blood about the compounds in the blood, concentration of CO2 and O2, and also about the blood pressure. So then those are important territories and functions of this. So then vagus is a little bit different, but very similar function and but more distal in the human body. More information about glossopharyngeus. Glossopharyngeus nerve has important, again, connection with the other nerves. So what's important? That ganglional nerves from glossopharyngeus are going into this plexus tympanicus, then are relayed in the ganglion oticum, and then it is a innervation of a parotis. So this is a parasympathicus. Glossopharyngeal nerve is then very important for innervation of salivary glands, and what is much more interesting, that we have a tympanal nerve, so which is nerve which is going into the tympanal cavity, making a plexus here, and also here are going important fibers which are sympathicus. Here we have a parasympathicus, and here from this plexus is constituting a nerve which is going on the surface of the petrosal bone and called petrosal minor, and then it's going to the ganglion oticum. So remember that the parasympathicus to the otic ganglion is going through the tympanal cavity. The innervation by glossopharyngeus. So parasympathicus for parotis. Sensitive for the base of a tongue behind the V-line of sulcus terminalis, including palatinal fossa. Then also sensitive innervation of a tympanal cavity, and also this tube, which is a tuba auditiva, tuba pharyngotympanotica, or tuba eustachi. Sensations in the throat, in oropharynx, and then important gustus sensations from the base of the tongue, and viscerosensitive information from the baro and chemoreceptors. So visceral. Very important. So this is a glossopharyngeus and very variable functions. The vagus has a very, very similar functions, but in different territories. Again, brachiomotor nucleus is ambiguous. Visceromotor here is called dorsalis nervi vagi. And if you remember, there was about salivatory for sevens, salivatory inferior 4/9, and this is a 4/10. Why so large? Because the distribution of a parasympathicus is here from the throat till the level of lienal flexure of a colon. So this is a very long territory of parasympathicus, which is supplied by vagus. So vagus is supplying thoracic organs and bronchi, lungs, heart, thymus, esophagus, then liver, stomach, gut, up to lienal flexure. It obtains also somatosensitive informations, and then these informations are transmitted to the trigeminal spinal nucleus. This somatosensitive, for you, the most important territories inside outer meatus, so in external auditory channel, inside you have the territory of vagus, and when you irritate inner space of outer auditory channel, you can then coughing, so it is important that it is the same. And what is sometimes very frequently forgotten, that there is also important part of gustus, of taste sensations. Those taste sensations are not from the tongue. This is from the epiglottis region, so from the aditus laryngis. So, about the vagus. About the vagus is very important that we have one important branch, which is very frequently forgotten again, and forgotten the curse. And this curse is extremely important according to the clinical symptoms. This is a nervus laryngeus recurrens. Recurrent nerve is a nerve which has a very interesting origin and important curse. This nerve is a branch which is going below the aortic arch on the left part and below the brachiocephalic trunk, or below the subclavian artery on the right side, and then is associated to the lateral aspect of the trachea, innervating this part, and then going into the larynx and innervating in the inner muscles of the larynx, especially in the vocal cord. And then the paresis of it cause the impairment of a voice, paresis of one cord. Could you imagine that there is a tumor? There is a large tumor which is arising from bronchi, bronchogenic carcinoma. When it's infiltrating the mediastinum, the main bronchus, then could infiltrate also this nerve, and the patient then could have and could, when you see into the larynx using laryngoscopy, you can see paresis of one vocal cords. So it could be caused in mediastinum, and it could be sign that the patient could have infiltrative involvement of mediastinum by bronchogenic carcinoma. So important. So about the vagus and vagus territories. Vagus territories could be important. You have this territory, which is outside and also inside the internal part of the external tube. So this is somatosensitive. Then somatosensitive from vagus, important territory, is a posterior fossa meninges. Then we have important motor innervation of the muscles in lower part of pharynx, then esophagus, then laryngeal muscles, and then we have taste. Taste is localized in epiglottis and around. And we have also viscerosensitive. Viscerosensitive information is obtained from gastrointestinal tube and derivates of it, from the embryonal part of development, so including tracheobronchial system and including part of the cardiac innervation, and then from the bodies. Here is a carotic, sorry, it's not carotic, it's aortic bodies, and those aortic and carotic upside. So those are typically baroreceptors in a vascular system, so obtain this information. The 11th nerve. The 11th nerve is partially, from the functional part, associated with the nerve which is previous one, vagus. Nervus accessorius has two nuclei. One is called nucleus spinalis. This is much more larger. It's quite long, and it's localized in a spinal cord. In a spinal cord, there are segments which are innervating muscles, like here. What is this muscle? Yes, and that one? Trapezius. And those, because they are really muscles, which are not muscles of a head, even if they are attached to it. So then these segments of a spinal cord are then creating such a strange cable, which is then going into the foramen magnum, into the intracranial space, and then escaping through this foramen jugular vein, where are also other two nerves, 9s and 10s, and then it is escaping and going the motor, somatomotor nerves, which are innervating two muscles. Then we have a second part. The second part is a nucleus ambiguus, but the lowest part, where is 11. Here we have 10, and here 9. And we know here that this is a nucleus which is a branchiomotor, and this is very interesting. Here, in the intracranial space, are assemblant, this from ambiguous and from spinal, to one nerve which is called 11th, accessorius. But directly in a foramen jugulare, it's split it into the branch which is then entering here, the vagus, in the inferior ganglion. And then it's going out and innervating the inner space of the larynx. So then this is a branch which forming recurrent laryngeal nerve. So when I will ask you during examination which nerve is innervating inner muscles of the larynx, forming a voice, so then you could correctly say that it's a recurrent laryngeal nerve. It's a branch of vagus. But when we will probably go to the levels of a nuclei, so then we can say that in reality it's a territory of an accessory nerve. Yeah? The last cranial nerve is a hypoglossus. Hypoglossal nerve is a pure somatomotor. It has, and you can see here, nicely seen those rootlets. If you remember rootlets from spinal cord and spinal nerves, they are forming spinal roots, And here we have two anterior roots, probably 0, C0, and C minus 1, because here is a C1. Because it is a really somate organization. And if you look at the part of oblongate, this lower part of oblongate is rolled together like a spinal cord and contains very similar structures assembled in a very similar organization. So then this nerve has a nucleus which is at the bottom of a fourth ventricle, and then it's created fibers which are crossing the structures of oblongate. What is this? So it is oliva, and this? What? I cannot hear it. It's a, you have said pyramid? No. So it's a pyramid. Yeah, this is a pyramid, and here is a corticospinal tract localized. Yeah, so it's anterior, oliva and pyramid, and here you can see these crossing fibers of a crossing part of the corticospinal tract. So then you can see that it's a very similarly organized, like C1, C2, C3. Epiglottis is a pure somatomotor, so for skeletal muscles, for muscles which are moving with the tongue. Then, again, we have here the structures which are going into the epiglottis channel. Then they are also a little bit associated with tense, but the fiber, which is a major fiber, which are going into these structures. So those structures are muscles moving with the tongue, and those muscles are cross-innervated from the other side of the cortex, like all muscles in the human body. So those muscles are inner muscles of the tongue, so transversus, verticalis, or longitudinal, and those which are moving, so typically here, which is genioglossus. So here is important relation between two nerves, hypoglossus and this one, trigeminus. Hypoglossus is a motor innervation of a tongue and a base of the four muscles. And then also hypoglossus is innervating, but not by the fibers rising from brainstem. It's innervating the muscles which are here, so muscles which are infrahyoid, because it's creating the large sling which is called ansa cervicalis. Ansa cervicalis has a radix superior and inferior, and there's a communication between C1 and C2, which are going for geniohyoideus, through the hypoglossus, and then also bridging these innervations for other parts. This sling, ansa cervicalis, is then very important for innervation of muscles which are in the throat outside, so muscles between hyoid bone and thyroid, and also hyoid, omohyoid, so those muscles which are localized in the anterior aspect of the larynx. Trigeminal nerve. We have said that through the mandibular nerve and its branch, lingular nerve, is provided the sensations from tongue and base floor, so it's only sensitive. So please remember, I distinguish like ophthalmic and optic, so it's a hypoglossus and lingualis. Both have in name the name of the tongue. So the last important information is about the genioglossus and innervation of it, because it's innervated partially by hypoglossus, partially from sensitive sensations from the other, but motor innervation could have affection on the other side of the, so when we have the cross innervation, so the motor neurons for left part lying in the right hemisphere, and then during the paresis you can observe some not completely strange. Probably you know that when you perform this motion of the tongue outside from the mouth, it's due to contraction of genioglossus muscle, and when is lacking the affection, the tongue is then going to the site of impairment. So patient's not able to move the tongue outside the mouth in a straight line. It's declined to the affected side. And then you can see also very important sign for central problems of the brain. Okay, it was everything about cranial nerves. Any questions? So why not?